toxicity is evaluated by monitoring for elevated blood urea nitrogen and serum creatinine levels. Cyclosporin does not depress the bone marrow.
If you want to see more videos, you can go to my YouTube channel, Alpha Nurse Guy.
Question 9. After kidney transplantation, cyclosporin is C. Elevated white blood cell count. D. Elevated blood urea nitrogen level. The correct answer is D. Elevated blood urea nitrogen level. Rationale: nephrotoxicity can occur from the use.
Prep for these case study questions that you're going to encounter on the next generation NCLEX exam. So let's get started. First, let's talk about how a case study question is different. So a case study is like this scenario of how a patient may present to you with a particular disease. And this scenario is going to build upon itself, and it's going to walk you through these certain questions of how you would handle this patient as they progress during their hospitalization or whatever with this particular disease. And these case studies are very similar to what you're going to encounter on the job. So they're very helpful in testing your nursing knowledge. For example, like how you're able to identify important symptoms, what labs are abnormal, and what you're going to do about it, and what to watch for, and how you're going to deliver care and provide patient education. So this whole scenario is going to try to capture your knowledge on that with this case study. So the big question that a lot of people are asking is, how do I prepare for these case study questions? Well, first you want to make sure that you're exposing yourself to next generation case study questions. And I have actually developed a mock next generation NCLEX case study that you may want to check out because I was going on with our patient. So as we're taking care of the patient, just like with an onion, we have to, in a sense, peel back those layers of the disease so we can get to the core of the problem so we know what to do for our patient. And those layers could be compared to the patho, the signs and symptoms, the labs and diagnostics, the treatment, the medication, and your role as the nurse. And you want to be familiar with all those different layers, because if you can get those layers of what's going on with your patient in your head, it's going to be like a domino effect for helping you just understand the whole disease process as a whole. So as you study and you're peeling back those layers of that disease, you got to make sure that you don't skip certain layers. Because if you do, it's going to make understanding these disease processes a lot more difficult, which could make answering case study problems more difficult. So let me illustrate this for you. Let's say you're studying heart failure. Okay, first thing you want to knock out, which layer you want to peel back first, is that pathophysiology. This is going to tell you what's occurring in the body, which systems are affected, and what causes it, and why it causes it. And this layer is going to be the toughest for you. It's going to take the most time of your learning, but it's the huge investment of your learning, because once you figure out what's actually going on with the patient, it's going to have that domino effect, and it's just going to allow those other layers to just peel right off, and it's just going to make so much sense. Because once we have figured out our patho, those signs and symptoms, they fall into place. And it's literally like you don't even have to memorize them, because with heart failure, you know we have a fluid volume overload. That's going to affect potentially, if we're dealing with right-sided or left-sided. If we're dealing with right, we're going to see a lot of peripheral problems because we're going to have systemic circulation overload, where the patient's going to gain weight. They're going to have edema, swelling, JVD. But with left side, we know that fluid can go in the lungs, so we're going to have a lot of pulmonary problems. And we learned all that information from our patho. Then when we go over to the layer of, okay, what do I need to know for labs and diagnostic reports? Because even though as a nurse we don't order these things are very important to us, because we need to know what we need to monitor for, what should be expected with that patient. And those abnormal signs and symptoms that you just learned about are going to help go along with those abnormal lab and diagnostic reports. Then that layer is going to feed into the patient's plan of care, where we want to be familiar with what treatments can be ordered by the doctor, what medications could we expect this patient to be on, what procedures or testing the patient may need. And then once we know that layer, it'll make our layer of nursing very easy to understand, because what we do goes along with a lot of the treatments that are ordered. So we want to know the big things that we do and don't do for the patient. What's going to help them get better versus what's not going to help them get better. And what to monitor and what to report, like with medications. What side effects are we monitoring for? We have a patient with heart failure. They're on loop diuretics. What are we monitoring for? We're going to look at their urinary output. We're going to look at their electrolytes, particularly their potassium level, and what information we provide them throughout their stay, along with discharge education and care. So the big takeaway from this is that as you study, you want to make sure in a sense that you're just surrendering yourself to the material, that you're just diving down into these diseases and learning all of the details about them, because it's going to help you in the long run. And that's why in my lectures, I really take time to go over these details with you and help you connect the dots, rather than just giving you this quick bullet list of information and just saying, here's the signs and symptoms, here's the causes. But instead, I want to connect those signs and symptoms for you and the causes. Because whenever you really take the time to understand this material, you're going to be able to easily recall it for exams, but most importantly, on that job. So this study strategy is an upfront investment, particularly in your time, but it's going to pay off majorly in the long run. Not only professionally for you, but whenever you take this next generation NCLEX exam. So I've been hearing some feedback from you all who have taken this exam, because it's been live for a few weeks now, and overall it's been very positive. People are reporting that they're passing, so that is good, and that they actually like these case study questions. So remember, the whole exam is not just case study questions. We still have the other types of questions that have been on there before. There's just these new case studies that have been introduced. So really try not to stress about these case study questions. Just try to study the best to your ability. I know that if you do that and just try to follow some of those tips I gave you, that you're going to do great. Hey everyone, it's Sarah, registerednursern.com, and in this video, I'm going to walk you through a case study similar to what you may encounter on the next generation NCLEX exam. So let's get started. So first, let's look at our case study summary. We have a 68-year-old male who's admitted with shortness of breath. He reports difficulty breathing with activity, lying down, or while sleeping. He states that in order to breathe easier, he has had to sleep in a recliner for the past week. The patient has a history of hypertension, a myocardial infarction 2 years ago, and a cholecystectomy 10 years ago. The patient is being transferred to a cardiac progressive care unit for further evaluation and treatment. So after I read this, what really jumps out at me is the patient's report about his difficulty breathing. He says he has difficulty breathing with activity, while lying down, and while sleeping. So with lying down, that is called orthopnea. This is when you can't really breathe very well when you lie down, so you have to set up and then you can breathe easier. And the difficulty breathing while sleeping is known as paroxysmal nocturnal dyspnea. And this is like a sudden attack that happens particularly at night, and the patient wakes up where they can't breathe and they have to set up to breathe. So to help this, the patient tells us that he's had to actually sleep in a recliner for the past week so he can breathe easier. Therefore, whenever I see these signs and symptoms of orthopnea and paroxysmal nocturnal dyspnea, I'm thinking that this patient may potentially have a cardiac disorder, because these are really presenting signs and symptoms whenever a patient has something wrong with their heart. So their shortness of breath could be related to their heart. And this is why a patient is going to the cardiac progressive care unit for further evaluation. So now let's look at our question 1 of 6. So it says that the nurse receives the patient admitted with shortness of breath. We see the nursing notes and we see the collected vital signs. And our question wants to know what findings are significant and require follow-up. And we need to select all that apply. So there's going to be multiple answers. So let's comb through this nursing note and vital signs to see what's abnormal and requires follow-up. Our nursing note starts out telling us that the patient arrived to the room via stretcher, which is fine. The patient is alert and oriented times 4, so they're alert and oriented to person, place, and time and event. And this tells us their neurostatus is intact so far. So the shortness of breath that they're having isn't affecting their mental function yet. So right now we have enough oxygen on board for brain activity. However, the nurse has noticed the shortness of breath with activity and talking, which should not happen normally. And this tells us something is wrong. It's significant, it requires us to follow up because we want to know why this is happening and is it going to get worse. And then it goes on to tell us that the weight and vital signs have been collected, and this is good. So the weight is 155 pounds, the BMI is 24, which is within a healthy range. Now this doesn't tell us too much, but it may be useful later on. It also says they're connected to a bedside monitor, so that's telling us that they need to be monitored constantly, like on a progressive care unit. And the monitor shows sinus tach. And this is significant because it seems the patient's shortness of breath is causing that heart to compensate by increasing that heart rate to provide more oxygen because the lungs are probably compromised. Then we do find out that yes, the lungs are compromised because crackles are heard in both lungs, and this is probably why our patient is having shortness of breath. So this is significant. You want to be thinking, okay, do we have pulmonary edema maybe? And then it says that the nurse has noted an S3, and this is like an S3 ventricular gallop, and this is an extra sound that is noted after S2. And what jumps out at me about this is that this is usually associated with a volume overload, like in the heart, and you see this in patients who have heart failure, some patients. However, an S3 can be normal in some people under 40 or during pregnancy, but this is not the case from what we learned in our case summary at the beginning. So this S3 gallop is definitely significant and does require follow-up. And in the back of my mind, I'm thinking, okay, maybe our patient has heart failure, but we need those test results back, like the echocardiogram, a chest x-ray, and hopefully in our labs will be a BNP, so we can see what those results are. It goes on to tell us that they have an 18 gauge in the left forearm, which is good, so we can give medications because I bet some are going to be ordered. We've had labs drawn and our testing results are pending. So now let's look at those vital signs that were collected. And as we look at those, you want to be asking yourself, okay, is this normal or not normal for this adult patient? The heart rate is 112, that is high. Sinus tach, which confirms what we've seen on the monitor because a normal heart rate in adults should be 60 to 100. Blood pressure is 176/98, that is hypertensive. A normal blood pressure, you want that top number to be less than 120 and less than 80 on the bottom. The patient's oxygen saturation is on the low side, and they are requiring 4 liters nasal cannula to be at 94%. And generally, we want it around 95% or higher. So this tells me the lungs definitely are not okay, and this is significant and requires follow-up. And the patient's respiratory rate is increased. It's 26. Normal is about 12 to 20. The temperature is 98.8. That is a normal temperature. And then the pain is just 1 out of 10. So the patient's not having significant pain. So since we've reviewed all this information, now let's answer our question. And again, our question wants us to select the findings that are significant and require follow-up, and there's going to be more than one answer. And as we select these answers, before we select it, we want to make sure that it's abnormal and that it does indeed require our follow-up. So be looking for answers that are abnormal with the A, B, C, D, and E. So our airway, breathing, circulation, and so forth. First up is heart rate. It's 112. This is abnormal. Definitely this is significant. We need to follow up. We need to bring that heart rate down and figure out why it's so increased. Temperature of 98.8, that's normal. That's not significant. Doesn't really require follow-up. We'll continue to monitor it, but it's okay for now. Pain, 1 out of 10, that's okay. Does not require follow-up, so we're not going to select that. Shortness of breath with activity and talking, yes, this is significant. It's not normal, so we are going to select that. Blood pressure of 176/98, yes, this is significant. We're going to select that because we need to get that blood pressure normalized. Weight of 155 pounds, no, that is not significant. A BMI of 24, that is not significant either, so we're not going to select either of those options. Sinus tachycardia, yes, this is significant. We are going to select that. Respiratory rate of 26, yes, that's significant. We're going to select that as well. S3 noted, this is abnormal as I pointed out earlier, so we are definitely wanting to follow up on that. And then lastly, an oxygen saturation of 94 4 liters nasal cannula. This is significant and requires follow-up, so we will select that. Now we're on question 2 of 6, and it tells us the nurse receives notification of new lab and diagnostic reports. So we see that our nursing note is the same. There's no added information, but we do have diagnostic reports back, a chest x-ray and an echocardiogram. We also have labs back that we can review. And our question says, for each patient finding, select if it's expected with left or right-sided heart failure. Some findings may be for both types of heart failure, and both columns will have at least one finding. So as our case study is progressing, it's starting to look like our patient does have heart failure. So what we need to do is we need to go and we need to review the diagnostic reports. What does our chest x-ray and echo say? And what does our labs tell us? And then we're going to go and look at what is presenting in our patient with their findings and try to select if this is left-sided or right-sided heart failure. So let's look at that chest x-ray. The chest x-ray shows cardiomegaly, which just means that the patient has an enlarged heart, and mild bilateral pulmonary vascular congestion, which is telling us that the patient has pulmonary edema. So that is why we heard crackles before. And then the echocardiogram shows that the patient has moderate left ventricular dysfunction with an LVEF of 35%. So LVEF means it's talking about left ventricular ejection fraction, and an ejection fraction tells us the amount of blood that is left that left ventricle with each contraction. So it's telling us how well that left ventricle is pumping out blood. And a normal EF is 50% or higher, and less than 40% is associated with heart failure. And our patient's EF is 35%. So that's telling us our patient has a low ejection fraction, and it does indeed seem like he is experiencing heart failure. And to us, from a nursing standpoint, this is further supported with the fact that we hear an S3 gallop and we hear crackles in those lungs. That tells us that blood is backing up from that left side into our lungs and causing congestion and causing the patient to have trouble breathing, which will go back to that orthopnea and that difficulty breathing that he was having sleeping at night, which is why he had to sleep in a recliner. Now let's look at the patient's lab reports. So here we have our patient's labs that were ordered. We see the patient's actual result, and then right beside of it we see the reference range. So we can see how abnormal it truly is and where it falls within the normal range. So first is sodium. Sodium for the patient is normal, but it's on the lower side of normal, which can happen with heart failure because blood volume increases and it can dilute the sodium in the blood. So with heart failure, you definitely want to monitor for hyponatremia. The patient's potassium level is normal, but it is on the low end of normal. So we definitely want to watch this level because chances are this patient is going to be ordered diuretics, and diuretics is going to help remove that extra fluid from the body. And if they're ordered loop diuretics like furosemide, that wastes potassium. So we definitely want to make sure that we're watching this level and that the patient doesn't experience hypokalemia. The calcium and magnesium are within normal range, and the BUN and creatinine are good as well. These are very important lab results that you want to watch on your patient because it tells us about their kidney function, and we're going to be giving them medications that act on their kidneys. So we want to make sure that their kidneys are performing well before we throw on a bunch of heart medications and diuretics. We also see blood glucose, which is 98. That is normal. But what's not normal is the patient's BNP, and it's 550. And according to the reference range here, any value greater than 400 picograms per milliliter indicates there's a high probability for heart failure. So it's definitely looking like our patient has heart failure. So let's talk about this BNP for a second. A BNP stands for brain natriuretic peptide, and this is a hormone that is released by the heart muscle when there is a high pressure in the ventricles that have stretched them, especially that left ventricle. So this high result of the BNP really corresponds with our echo results of what we've seen with the patient having compromised left ventricular ejection fraction and the chest x-ray where their heart is enlarged. So with those diagnostic results, we can see that definitely our patient has heart failure. Then next we see that we have troponin levels, CKMB and CK levels, which are all within normal range. These are like cardiac markers that we'd want to look at to see if there's any damage to that heart muscle. And here we're not seeing any at this moment. And then the hemoglobin and hematocrit are within normal range. They're a little little bit on the low side of normal, but that's okay right now. But one thing to keep in mind with patients with heart failure is that they can experience anemia, so we want to just keep an eye on that. And then our platelets and white blood cell count are within normal range. So since we've reviewed all that information, now let's answer our question. And again, our question wanted us to select Hey everyone, it's Sarah, the registered nurse, RN.com. In this video, I'm going to walk you through a case study similar to what you may jugular venous distension, which is JVD. In addition, fluid is going to answer our question. And again, our question wanted us to select which patient findings would be associated with left or right-sided heart failure. And to help us answer this question, we have to think back to the patho of heart failure. And to do this, try to visualize the heart in your head and divide it into the right side of the heart versus the left side of the heart. And think of which side is connected to what parts of the body. Because what's happening in heart failure, the heart is failing to pump blood forward. So that blood is going to go backward. And this can happen either on the right side or left side. A lot of times if it's left side, it's also going to affect the right side. So with right-sided heart failure, if blood can't go forward on that right side, it's going to go back into the right atrium, into the vena cava, which is going to hit our venous circulation. So you're going to start seeing problems with liver enlargement. You're also going to see jugular venous distension, which is JVD. In addition, fluid is going to build up in the abdomen, causing ascites, and the patient is going to have edema in their extremities. So those are big telltale signs of right-sided heart failure. Now with left-sided heart failure, the blood, again, can't go forward, so it's going to go backward. It's going to go up through that left atrium, and it's going to hit the lungs. So instead of hitting the venous circulation like how our right side did, on our left side, it's going to hit that lung. So you're going to get a lot of pulmonary symptoms, where you're going to see respiratory problems, the shortness of breath, the crackles, orthopnea, the difficulty breathing at night while you're sleeping, and that pulmonary edema that you've seen on the chest x-ray. So with all that knowledge in our head, let's look at the patient's findings and say if it's left or right-sided. So first up is shortness of breath. This is a pulmonary issue. This is going to happen with left-sided, so we're going to select left-sided. Next is sinus tachycardia. So is this going to be with right or left-sided heart failure? With this, it can actually present in both, because in heart failure, you have fluid volume overload and you have a weak heart. So that can really tax the heart out. A last-ditch effort on its part will be to try to increase its rate so it can maintain cardiac output, maintain oxygen throughout the body. So this can actually be for both, so we're going to select both with this one. Chest x-ray with mild bilateral pulmonary vascular congestion, that is going to be found in left-sided heart failure. A blood pressure of 176/98, hypertension, that can actually present with both right side and left side, because again, it goes back to that volume overload in the heart. So that's going to increase pressure. So we'll select both of those for this one. Crackles, that is with the pulmonary edema, that is associated with left-sided, so we'll select left-sided. Now let's look at question 3 of 6. So we look at our nursing notes and we see that an entry has been made at 13:30 that says labs and diagnostic reports are back, and Dr. Smith has been notified of those results and will continue to monitor patient. But there's no other new information with diagnostics or lab. So let's look at our question. It says to select the words that best complete the sentence below. The sentence says the nurse suspects the patient is experiencing left-sided or right-sided heart failure, so we have to select either one, as evidenced by the patient's shortness of breath, testing results, or sinus tachycardia. So this question here builds on the question we just answered, and based on what we have figured out, the patient is experiencing left-sided heart failure. So we really had to understand how last question in order to get this question right, because it's really just bringing it all together. So we already know off the bat the patient is experiencing left-sided heart failure, so we can select that. Now we need to figure out by what evidence. does that help support that left-sided heart failure? So let's look at the options. We have shortness of breath. Well, does that provide 100% evidence that, yes, this patient is having left-sided heart failure? No, not really, because shortness of breath can present with other conditions like lung conditions and heart conditions. So it doesn't tell us 100% the patient has heart failure. How about testing results? We've seen chest x-ray and echocardiogram and BNP, and those were pretty convincing that the patient's experiencing heart failure. So we're going to keep that in mind, but let's look at the next one, which is sinus tachycardia. Well, sinus tachycardia can present with other conditions, so that's not 100% confirmation that there is heart failure going on. So testing results is the best. So our sentence will say the nurse suspects the patient is experiencing left-sided heart failure as evidenced by the patient's testing results. So testing results is just the best to support that the patient has this. Now let's look at question 4 of 6. So it says the patient has been given the diagnosis of left-sided heart failure, which is what we were already thinking as the nurse. So that's good that it's confirmed. And that we see in the nursing notes another entry has been made. It tells us that Dr. Smith is at the patient's bedside discussing treatment and new orders. And then whenever we go down to our question wants us to look at those nursing actions and determine what nursing actions will be implemented for this patient and select all that apply. So we see nursing actions over there on one side, and then we see implemented versus not implemented. So let's go and look at what new orders we have. And it looks like it's medication orders. So the patient needs to be started on furosemide, 40 milligrams IV twice a day. And furosemide is a loop diuretic, and as I pointed out earlier, these can waste potassium, so we definitely want to monitor our potassium levels. But below that, we also see that potassium 40 milliequivalents by mouth has been ordered twice a day, so hopefully that's going to help combat this hypokalemia that can potentially be experienced. Patient's also been ordered lisinopril 2.5 milligrams PO daily, and lisinopril is known as an ACE inhibitor, and this is going to inhibit the renin, angiotensin, aldosterone system. So what this is going to do is going to help with the heart failure. It's going to help decrease that blood pressure, help decrease the afterload. The resist. So I've been ordered lisinopril to notes. Another entry has been made. It tells us that Dr. Smith is at the patient's bedside discussing treatment and new orders. And then whenever we go down to our question wants us to look at those nursing actions and determine what nursing actions will be implemented for this patient and select all that apply. So we see nursing actions over there on one side, and then we see implemented versus not implemented. So let's go and look at what new orders we have. And it looks like it's medication orders. So the patient needs to be started on furosemide, 40 milligrams IV twice a day. And furosemide is a loop diuretic, and as I pointed out earlier, these can waste potassium, so we definitely want to monitor our potassium levels. But below that, we also see that potassium 40 milliequivalents by mouth has been ordered twice a day, so hopefully that's going to help combat this hypokalemia that could potentially be experienced. Patient's also been ordered lisinopril 2.5 milligrams PO daily, and lisinopril is known as an ACE inhibitor, and this is going to inhibit the renin, angiotensin, aldosterone system. So what this is going to do is going to help with the heart failure. It's going to help decrease that blood pressure, help decrease the afterload, the resistance, which is the resistance the ventricles must overcome to pump out blood. So it's going to help our heart pump more efficiently. Digoxin 0.25 milligrams PO has been ordered daily as well, and this is also going to help our heart function. It's going to improve how well the heart can contract, making those contractions stronger but slower, and increasing our cardiac output. And then morphine 2 milligrams IV has been ordered as needed PRN for pain or anxiety. And morphine can actually help not only alleviate pain, but it can have some cardiac properties as well by helping decrease our preload and our afterload, and just decrease the anxiety that the patient's going to be experiencing with this pulmonary edema that they're having. So help them breathe a little bit easier without the anxiety involved. Now let's jump back to our question and let's look at what we need to do for this patient. So to answer this, you need to think back to a heart failure patient. What do you want to implement for them, and what do you not want to implement? And remember, we're dealing with respiratory problems, fluid volume overload, new medications that can alter electrolytes and fluid status, and we're dealing with a weak heart. So we want to select nursing actions that's going to promote healing, hence help them get better, not make them worse. First up is strict intake and output. Yes, we definitely want to select this for implemented. Because the patient is experiencing fluid volume overload, they're going to be receiving medications to promote the removal of water through their urine. So we want to know exactly how much is being taken in and how much is being put out. This is going to tell us are we removing enough fluid and make sure we're not hurting the kidneys, that they're putting out enough urine per hour. Keep head of bed 15 to 30 degrees. This is pretty low, especially for someone who's having breathing difficulty because they have fluid in the lungs. So no, we would want to select not implemented for this because orthopnea is a common symptom with heart failure and lying down makes their breathing worse. So we want to put them upright in like high Fowler's position with their legs dangling to help reduce venous blood return and to help decrease that preload. Monitor for hypokalemia? Yeah, definitely. We want to implement this, so we'll select that. Because furosemide is going to waste potassium. If our potassium drops too low, it can actually increase the risk of digoxin toxicity, which is what they're on. So we want to make sure we definitely monitor the potassium levels. Increase venous blood return and to help decrease that. Lying down makes their breathing worse. So we want to put them upright in like high Fowler's position with their legs dangling to help reduce venous blood return and to help decrease that preload. Monitor for hypokalemia? Yes, definitely. We want to implement this, so we'll select that. Because furosemide is going to waste potassium. If our potassium drops too low, it can actually increase the risk of digoxin toxicity, which is what they're on. So we want to make sure we definitely monitor the potassium levels. Encourage fluids? No, we don't want to do this, so that's under not implemented. Because most likely this patient's going to be on a fluid restriction, anywhere between 1.5 to 2 liters per day. We want them to drink really only when they're thirsty and to spread this throughout the day. So we don't want to just encourage them to take in lots of fluids. Weigh daily, we definitely want to implement this because monitoring a patient's weight is one of the best ways we can monitor their fluid volume status. And we want to do this at the same time every day with the same scale. Monitor EKG, definitely implement this because they're at risk for lethal rhythms, just with heart failure in general. We don't want them to go in defib. And then plus, they're on cardiac medications like digoxin. We want to make sure that they're not getting bradycardic or they're having
implemented, not
problems with their
implemented.
rhythm. Instruct to limit foods high in potassium. No, this would not be implemented because again, we potentially have a problem with wasting too much potassium. We don't want to limit the foods in potassium, but we want them to eat a normal amount. Monitor apical pulse. Yes, we want to implement this. This goes back to the digoxin. So you want to know as the nurse with digoxin administration that you always measure this pulse and that you would hold it if it was less than 60 and notify. This would not be implemented because again, we potentially have a problem with wasting too much potassium. We don't want to limit the foods in potassium, but we want them to eat a normal amount. Monitor apical pulse. Yes, we want to implement this. This goes back to the digoxin. So you want to know as the nurse with digoxin administration that you always measure this pulse and that you would hold it if it was less than 60 and notify the doctor for further order. So we definitely want to do this. Monitor blood pressure. Absolutely. This would be under implemented because again, we're diuresing this patient. We want to make sure that we're not going to make them hypotensive where we remove way too much fluid. And we want to make sure that their blood pressure is normalizing because remember at the beginning it was high. Implement a high sodium, low fat diet. No, this would not be implemented because just thinking back to heart failure, we have fluid volume overload. We know that sodium attracts water. So if they take in a lot of sodium, they're going to retain a lot of water. And we are not wanting this to happen because implement a high sodium, low fat diet. No, this would not be implemented because just thinking back to heart failure, we have fluid volume overload. We know that sodium attracts water. So if they take in a lot of sodium, they're going to retain a lot of water. And we are not wanting this to happen because we're actually trying to remove this water. So they would actually be on a low sodium diet. And then lastly, keep oxygen saturation greater than 95%. Yes, we want to do this, so we will click implement. Now let's look at question 5 and 6. It says the nurse reassesses the patient's condition after implementation of the orders. So let's quickly look at our question. It says, what findings demonstrate the patient is improving? Select all that applies. Now let's look at what we have new. So in our nursing notes, we see at 1400 that medications have been given per Dr. Smith's orders, and the patient was educated educated on new medications and given a urinal to collect urine, because remember they're getting diuretics, so they're going to be voiding a lot. The patient verbalized understanding about the importance of helping keep track of amount urine voided, and bedside monitor connected, continued to monitor. Then we see several hours later at 1700, the patient has voided a total of 750 mLs of clear yellow urine in the urinal. So that tells us our diuretic is working, and this is going to help decrease fluid from in the lungs, lower that pressure in the heart, and lower our blood pressure. And then the rhythm is normal sinus rhythm on the cardiac monitor, and the patient is eating dinner with their spouse at the bedside, and we'll continue to monitor. We're told that the vital signs, heart rate 88, blood pressure 130/80, oxygen saturation is 96% on 3 liters nasal cannula, respiratory rate 16, temperature is 98.6 degrees, and our pain is 1 out of 10. So from that, we see our heart rate has decreased, our blood pressure has decreased, respiratory rate is decreased, and our oxygen saturation is 96%, and they're actually down to 3 liters nasal cannula. So that is good. From that new information, we can see that there are some things that tells us our patient has definitely improved. So let's see what our options are. The temperature of 98.6, that is still normal, so it's the same. So we're not going to select that. Really, there's been no improvement. It's maintained itself. 750 mLs of voided urine, that is a good sign, and that shows us the patient is improving. They're getting rid of this fluid that's in their heart and their lungs so they can function easier. So we're going to select that. Next is patient is eating. Does this show us that the patient is improving? And the answer is yes, it actually does. Because let's think back to eating. Eating takes a lot of breathing effort. You have to chew and you have to swallow. And whenever you have a patient who has respiratory issues, like this patient here with shortness of breath, it can really tax them with just the task of eating. So the fact that they're up and eating tells us that their respiratory system must be doing okay if they feel like eating. Plus, they have an appetite and they're not nauseous or experiencing vomiting, which is something you definitely want to watch for whenever a patient's taken digoxin, because GI upset is one of the early signs and symptoms of digoxin toxicity. So this tells me that it's a good sign. So we're going to stop this. 3 liters nasal cannula. This is an improvement from before, because remember at the beginning of our case study, our patient was on 4 liters. So they're maintaining 96% on 3 liters. So this is an improvement. Pain of 1 out of 10. This is the same. We're not going to select this. And then normal sinus rhythm. This is definitely an improvement, because before the patient was experiencing sinus tachycardia. And then finally, question 6 of 6. So here we're told after a few days of hospitalization, the patient is ready to go home. The nurse is providing discharge education to the patient. And the question in this part of the case study says the nurse has provided discharge care instructions about heart failure to the patient. What statements by the patient require re-education? So let's look and see what new information we have. We see in our nursing notes at 9 o'clock that discharge orders have been received. Home health nurse is present with the patient discussing program options and home care setup. A lot of times patients who have heart failure will go home with a home health nurse who will come out to see them and just help monitor their heart failure. And then we see the discharge medications that the patient's going to go home on, which is like furosemide, potassium, lisinopril, and digoxin. So to answer this question, what we need to do is we need to look at the patient statement and then ask ourselves, is this something a patient with heart failure should do? And if it's not, they need to be re-educated. The first one is, I will notify my doctor if I gain more than 2 pounds in a day. This is a correct statement, so no re-education is needed. With heart failure, the patient wants to make sure that they don't gain more than 2 to 3 pounds in a day or 5 pounds in a week. If they do, they need to contact their doctor, because it can be an early sign that heart failure is coming on and that heart is starting to fail and it can't deal with the extra fluid. Next, I will weigh myself at the same time each week. This is not a correct statement, so re-education is needed. The patient should weigh themselves daily at the same time each day, not weekly. And weight gain is an early sign that the patient is gaining fluid and the heart is starting to fail. So if they do have this happen, they would want to contact their doctor for further care. Next, nausea and vomiting is an expected expected side effect of my medications. This is incorrect and requires re-education. The patient is actually going home on digoxin, and as I discussed before, digoxin has a risk of toxicity with it, and this risk actually increases with hypokalemia, which the patient could potentially experience since they're on furosemide, and nausea and vomiting is one of those early signs and symptoms. Therefore, the patient really needs to be educated. If they experience this, they should report it immediately and not just dismiss it as an expected side effect. I will miss eating spinach, broccoli, bananas, and avocados. This is an incorrect statement and re-education is needed. So with this, how you would know is you need to ask yourself, okay, what do all of these foods that the patient just listed, what do they have in common? What they have in common is that they're all high in potassium, and the patient shouldn't limit these foods because, again, we have a risk of hypokalemia with the furosemide. They want to eat a normal amount of potassium along with taking a potassium supplement, not to just cut off potassium completely. I will follow a low sodium diet. This is correct, so no re-education is needed because patients with heart failure should consume less than 2 grams, which is 2,000 milligrams of sodium per day. And also they want to watch out for hidden sodium in like soft drinks and processed foods because remember, water loves sodium and more sodium draws in more water, which can exacerbate heart failure. And then lastly, I will use sugar-free candies if I develop a dry hacking cough. This is an incorrect statement and re-education is needed, so we'll select that. Now, a dry hacking cough should not be ignored because it could be a sign that heart failure is getting worse and that the patient needs to be evaluated. It's one of those early signs along with the weight gain. However, one thing you want to remember is that lisinopril, which is an ACE inhibitor, can cause a dry hacking cough. However, regardless of this dry hacking cough should be evaluated and not just ignored by sucking on hard candies to keep it from happening because the cough could be due to like maybe the lisinopril, which the doctor could switch them to an angiotensin receptor blocker, an ARB, or indeed the heart failure is exacerbating itself. So they need to be further evaluated. Okay, so that wraps up this video. If you'd like to watch more videos in this series, you can access the link in the YouTube description below. Hey everyone, it's Sarah, the registered nurse, RN.com, and in this video, I'm going to be reviewing wheezes. First, let's listen to some sample audio of what wheezes may sound like.
Sama tayo.
Now, how do you know that you're hearing wheezes? Well, you want to pay attention to the timing. With wheezes, you're mainly going to hear them on expiration where they're going to be the loudest, but you can note them on inspiration and expiration. And their pitch is going to be high. In addition, they're going to be continuous and located throughout the respiratory system. And they will have a defining characteristic when you listen to them. They will have this squeaky musical whistling noise to them. And you may even be able to hear them without a stethoscope, especially if your patient's having an active asthma attack. Now, it's important whenever you hear these sounds that they're not mainly coming from the throat area, because this may indicate stridor. And again, let's listen to that audio of what wheezes could sound like. So why is this sound occurring? Well, it occurs because the airways have started to narrow, meaning they have started to get smaller. So as air is squeezed through those airways, it creates this squeaky musical whistling sound. And it can occur in cases of asthma, COPD, or any type of lung infection that narrows those airways, like with a viral respiratory infection. Okay, so that wraps up this video on wheezes. And if you'd like to watch more videos in this respiratory series, you can access. Hey everyone, it's Sarah, registered nurse, RN.com, and in this video, I'm going to talk about different types of adventitious lung sounds. So let's get started. Adventitious lung sounds are abnormal sounds that you hear during auscultation that shouldn't be there. And I want to cover 5 main types that you want to be familiar with. The first type is known as crackles. These are also sometimes called rels, and you can further divide them into fine crackles and coarse crackles. There's also wheezes, rhonchi, stridor, and pleural friction rub. Now, whenever you're auscultating lung sounds and you're trying to identify that particular abnormal sound that you're hearing, you want to make sure that you ask yourself the following questions. The first question deals with timing. Ask yourself, are you hearing this mainly on inspiration or expiration, or even both? Then try to determine the pitch of the sound. Is it high pitched or low pitched? Followed by if this sound is considered discontinuous or continuous. This refers to the length and the nature of that sound or sounds produced. For example, if the abnormal sounds are distinguishable individually and occur in succession, such as the individual pops and fine crackles, and those sounds generally last less than 250 milliseconds, the sound is considered discontinuous. However, if the sound is more constant in nature, generally lasting longer than around 250 milliseconds, it is considered continuous. And then another question you want to ask yourself is about location of that sound. Where are those sounds mainly heard? Are they mainly heard in the large airways, like the trachea?
Nakakatawa ba? Nag-aaral ako ng ganito. Mas magaling pa siyang makatanda. pag, pag may mga questions, nakakasagot pa siya. Ay, nako.
The large bronchi or
Lalaying
the
sa
smaller
psych mo.
airways, which involves the
Lalaying sa
alveoli
psych.
and bronchioles. And then lastly, try to determine if this sound has a defining characteristic to it that's just really hard to ignore. For example, the sound sounds like a harsh grating noise, or squeaky musical whistling, or snoring, or squawking, which could hopefully help you determine what kind of sound you're hearing. So first, let's go over crackles. Fine crackles are sometimes referred to as rels. And the first thing what I want to do is I want you to listen to an example of what fine crackles may sound like. Now, how do you know that you're hearing fine crackles? Well, you want to pay attention to the timing. With fine crackles, you're going to hear those towards the end of inspiration, and they're going to be really brief. You also want to pay attention to that pitch. Fine crackles are going to be high-pitched. You also want to make sure that they are discontinuous, meaning that you're able to distinguish those individual popping, cracking sounds that are occurring in a series, so they're intermittent. And these sounds tend to be located in small airways. Plus, they're going to have this defining characteristic. They're going to sound very similar to popping or light crackling of a fire, and they cannot be cleared with coughing. And again, let's listen to that sample of fine crackles. Now, what's causing this sound? Well, whenever the patient breathes air into those small airways, like the bronchioles or the alveoli, which are deflated or collapsed, it causes them to all of a sudden crackle or explode open, which allows you to hear that high-pitched crackling noise. And fine crackles can occur in cases of congestive heart failure, atelectasis, pneumonia, and pulmonary fibrosis. Next up is coarse crackles. Let's listen to some audio of what coarse crackles may sound like. Now, how do you know that you're hearing coarse crackles? Well, you want to pay attention to their timing. Coarse crackles tend to occur around the beginning of inspiration, but they can extend into expiration, and they tend to be longer than fine crackles. Also, their pitch is low and they are discontinuous. In addition, they tend to be located in the large airways, such as the bronchi, and they have specific defining characteristics. These coarse crackles tend to sound like a gurgling or bubbling sound that is not cleared with coughing. And again, let's listen to this audio of coarse crackles. Now, what causes this sound? Well, it tends to occur whenever patients breathe air into partially blocked airways, like those large airways such as the bronchi, that are filled with fluid or really thick mucus. So whenever you're trying to think of lung conditions that will cause this sound, think of lung conditions that present with fluid or thick mucus. And these conditions could include heart failure due to pulmonary edema, which is fluid in the lungs, or severe cases of pneumonia, or bronchiectasis, which is a chronic lung condition where the bronchi are enlarged due to chronic lung disease, for example, like cystic fibrosis, or infections that result in mucus secretions. Now let's talk about wheeze sounds. First, let's listen to some sample audio of what wheezes may sound like. Now, how do you know that you're hearing wheezes? Well, you want to pay attention to the timing. With wheezes, you're mainly going to hear them on expiration where they're going to be the loudest, but you can note them on inspiration and expiration. And their pitch is going to be high. In addition, they're going to be continuous and located throughout the respiratory system. And they will have a defining characteristic when you listen to them. They will have this squeaky musical whistling noise to them, and you may even be able to hear them without a stethoscope, especially if your patient's having an active asthma attack. Now, it's important whenever you hear these sounds that they're not mainly coming from the throat area, because this may indicate stridor. And again, let's listen to that audio of what wheezes could sound like. So why is this sound occurring? Well, it occurs because the airways have started to narrow, meaning they have started to get smaller. So as air is squeezed through those airways, it creates this squeaky musical whistling sound. And it can occur in cases of asthma, COPD, or any type of lung infection that narrows those airways, like with a viral respiratory infection. Next is rhonchi. So let's listen to some audio of what rhonchi may sound like. Now, how can you know that you're hearing rhonchi? Well, you want to Now, how can you know that you're hearing rhonchi? Well, you want to pay attention to Now, how can you know that you're hearing rhonchi? Well, you want to pay attention to the timing. Rhonchi are mainly heard on expiration, but you can hear them along with inspiration. And they're going to have a low pitch and be loud. In addition, they're going to be continuous and located in large airways, like the trachea and the bronchus. And they're going to have a defining characteristics, where when you listen to that sound, it's going to sound like a snoring or a snorting sound that can decrease or go away with suctioning or coughing. Now, it's important to note that some literature will actually classify rhonchi as a type of coarse crackle or a type of wheeze. So whenever you're trying to identify these lung sounds, always go by the facility or your professor's recommendations for how they want you to categorize rhonchi. So again, let's listen to that audio of rhonchi. Now, what causes this sound? Well, it occurs whenever air leaves the trachea and bronchus and it hits secretions like mucus and fluid. And whenever it does this, it creates this snoring-like sound that you're hearing. And this can happen in cases of bronchitis, pneumonia, and COPD. Next is stridor. So let's listen to some audio of what stridor may sound like. Now, how do you know that you're hearing stridor? Well, you want to pay attention to a few things. First thing is timing. Stridor can be heard on inspiration, so that you're hearing stridor. Well, you want to pay attention to a few things. First thing is timing. Stridor can be heard on inspiration or expiration, and it's going to have a high pitch. In addition, it's going to be continuous and located mainly in the upper respiratory system, like the trachea/throat area. And it's going to have a defining auditory characteristic that you really can't ignore. It's going to sound like this screeching, squawking noise that's coming mainly from that throat area. So again, let's listen to this audio of stridor. So what causes this sound? Well, it's occurring because there's narrowing of the larynx and the trachea from swelling due to some type of infection or blockage from an object. And it can actually progress where that airway will be completely blocked off. Therefore, some cases of stridor are life-threatening and require immediate attention. So it depends on the severity of the stridor, how severe does it sound, and what is actually causing it. Stridor can be caused by cases of epiglottitis or croup, where you may hear it referred to as a barking cough in the pediatric population. It can also be caused in cases of anaphylaxis or if there is an object stuck in this throat region. Finally, we have pleural friction rub. So let's listen to some audio of what a pleural friction rub may sound like. that you're hearing a pleural friction rub. Well, you want to pay attention to the timing. With pleural friction rubs, they can occur on inspiration and expiration, and they're going to have a low pitch to them. In addition, they can be discontinuous or continuous. It really depends on the severity of the rub and what's going on with your patient. And it's located in the pleura layer, which are the layers that surround your lungs, which is made up of the viscera pleura and the parietal pleura. In addition, it's going to have a defining characteristic that you're going to be able to note on auscultation. You're going to hear this harsh grating sound. In addition, your patient's probably going to have pain, especially when they take deep breaths in or they cough. Now let's listen to that audio of a pleural friction rub again. So what causes this sound? Well, it occurs whenever those pleural layers become inflamed and rub up against each other, because normally the visceral and the parietal pleura are separated by a small space. So as the patient breathes in, those layers will just glide over one another. But when those layers become inflamed, that space shrinks, which allows those layers now to rub up against each other, creating pain and that harsh grating noise that you're going to hear. And it can happen in cases of pleurisy, which just means inflammation of those pleural layers, pneumonia, pulmonary embolism, tuberculosis, and some forms of lung cancer. Okay, so that wraps up this video. And if you'd like to watch more videos in this respiratory series, you can access the link. Hey everyone, it's Sarah with RegisteredNurseRN.com, and in this video I'm going to talk about benzodiazepines. And as always, whenever you get done watching this YouTube video, you can access the free quiz that will test you on this material. So let's get started. Benzodiazepines, also known as benzos or BZDs, are a group or class of drugs that actually calm the central nervous system. Therefore, they're known as CNS suppressants. Now, these drugs can have an anxiolytic, sedative, or hypnotic effect on the body. And whenever we talk about the mechanism of action, how these drugs actually work on the body, like with the receptors and the specific neurotransmitter it affects, you're going to see how these drugs actually cause these effects to occur in our body. Now, whenever you're studying these drugs, you're going to see that there's various types of benzos available for use. Some are very potent, some are short-acting, some are long-acting. And it really depends on what's going on with the patient to determine what type of benzo should be used. Now, how do you recognize a benzodiazepine? Say you're looking at a patient's list, how do you know if this is a benzo or not? Well, there's two things you can look for, and you're looking at that generic drug name. The first thing is look at the middle of that name and look for a ZE or a ZO. In benzodiazepine, we have a ZE present in the name. That usually tips you off that this is a benzo. Another thing that you can look at is that most end in LAM or PAM, except for two, and this includes chlorazepate and chlorodiazepoxide. Now, some popular ones that you will see in practice that do follow those two rules are alprazolam, lorazepam, clonazepam, tenazepam, diazepam, and midazolam. So now let's talk about what benzos are used for. What conditions are they really good at treating? Well, we've established that benzos are CNS depressants. So they're really good at treating conditions where there is too much CNS stimulation, where these neurons are just rapidly firing, we have too much activity going on up there. So we need to calm things down, and they're great at treating patients who experience anxiety, seizures, panic attacks, or whenever they're withdrawing from alcohol. Or they're having trouble sleeping, like insomnia. They can also be used before a procedure. And many times I have given a patient before a TEE, a transesophageal echo, or a cardioversion, Versed. That is midazolam. And this helps calm that patient down. It also helps them not really remember the procedure. And so they're really helpful for that. And these medications can be given various ways. You can give them IV, you can give them PO, IM, intramuscular, rectally, etc. Now let's talk about the mechanism of action and how benzos work to actually depress the central nervous system and to provide that calming, tranquilizing effect on the body. Well, in order to achieve this, it all deals with a neurotransmitter, specifically known as GABA. And GABA stands for gamma aminobutyric acid. So whenever a benzo is on board in a patient's body, what it's going to do is it's going to amplify the effects that GABA already normally has on that central nervous system. So it's going to exaggerate the effects that we need in order to treat whatever conditions going on with our patient. Now, GABA is considered an inhibitory neurotransmitter. Now, what does that mean? Well, first, let's talk about neurotransmitter. A neurotransmitter is a chemical agent that is produced and released by a neuron, hence why we call it a neurotransmitter, and it transmits messages to a specific structure that it was actually designed to communicate to. This could be a gland, or many times it's a neuron. So it's going to send these specific messages. And these neurotransmitters, I like to think of them as like little raindrops that are raining down, and they're going to go to where they need to go on, let's say, that neuron, because that neuron that it's communicating with is going to have these special receptors that are just going to sit there and accept that specific neurotransmitter. So this neurotransmitter can either have an excitatory effect on that specific structure it's designed to target, like that neuron, or an inhibitory effect. Now, sometimes neurotransmitters can have both effects, but it really depends on where they're acting in the body. But GABA is one of the main inhibitory neurotransmitters. So let's talk about the difference between an excitatory and inhibitory real quickly. So an excitatory neurotransmitter, what it's going to do is it's going to excite, and it's going to increase the potential of an action occurring, like the neuron firing and sending that message. So it's going to make sure that message is sent. An inhibitory neurotransmitter, just as its name says, it's going to inhibit. So it's going to decrease the potential of an action occurring, so it's not going to really allow it, and it's going to inhibit that message from being sent. So that's where GABA gets its qualities, because it's going to decrease that firing of that neuron so that patient can chill, have that calming, tranquilizing effect on the body. Now, to help us really understand and see how these neurotransmitters actually are released from the neuron onto a receptor site, let's look at this animation. So here you can see that this neuron is releasing a neurotransmitter. The neurotransmitter is in yellow, and it's raining down. And for that neurotransmitter to be successful to send whatever message it needs to send to the other neuron, whether it's an exciting or inhibiting message, it must bind onto its special receptor, which will help complete that action. Now, when the neurotransmitter GABA is released from its neuron, it's going to go and bind with GABA receptors. And many GABA receptors are found in our limbic system. And this is a system that helps us process our emotions and really dictates the way that we behave. So there are two types of GABA receptors. There's GABA A receptors and GABA B receptors. Benzos are going to specifically affect the GABA A receptors. So that is what you want to remember. GABA A, that's what we care about for this lecture. So GABA A are really interesting because they are considered ligand-gated or ionotropic receptors. And these terms just really describe how they work and how they operate whenever they are being affected by, let's say, benzodiazepines. So whenever binding occurs, so we have benzo binding to the receptor along with the neurotransmitter GABA neurotransmitter, which you're going to see here in a second, it's going to cause a channel to open. And whenever that channel opens, ions are going to move into the cell. And whenever this occurs, it's going to cause hyperpolarization. And this is going to cause that inhibitory action where it's going to inhibit potential action from occurring. Hence, we're going to get calming effects. And we're specifically talking about the ion chloride. So now let's take a closer look at these GABA A receptors and look at their unique design and how they work to actually cause this effect. So hopefully it'll seal this concept in your mind. Okay, so the GABA A receptor has these divisions, and it's divided into 5 subunits. You have 2 alpha subunits, 2 beta subunits, and 1 gamma subunit. And on these subunits, we have a total of 3 binding sites. There are 2 sites that are for the neurotransmitter GABA. And GABA will go here and bind with this receptor in between both of the alpha and beta subunits. Then we have a binding site specifically for the benzodiazepine chemical. And it's going to bind here in between alpha and gamma. So it has its own little special site. And in between all of these subunits, right there in the middle, is like this little opening, this pore. And this is what will open and allow our ion to move down into the cell and cause hyperpolarization. So we have GABA neurotransmitter raining down from our neuron, and it goes, and it sets at this binding site, and it locks down on it. So there's our GABA. Then the patient has taken a benzo, so that chemical is there in the body. It's going to be here, and it's going to bind to its site. And whenever this occurs, what's going to happen is that this channel down here is going to open up. And once it opens up, these chloride ions, which are negatively charged, are going to go down into this cell. What this does is it causes hyperpolarization. It's going to make it negative. And this is going to decrease firing potential. So decrease that action potential. And it's going to, hence, cause a calming, tranquilizing effect. So we're going to have an amplified effect of how GABA would normally work on that central nervous system. So this is great for a patient who is having anxiety, panic attacks, or having those withdrawal symptoms from alcohol. Will help depress that central nervous system. Now let's wrap up this lecture and let's talk about the nursing responsibility.
Isa pang nakaka-toxic. Isa pang nakaka-pressure ba? Kasi kailangan tama yung pag-pronounce mo. Withdrawal. Withdrawal. Magsabi ka withdrawal. Magsabi ka withdrawal pagtatawanan ka. Halimbawa yung yung pangalan ng gamot. Ay yung sa atin na Robitussin? Sa atin Robitussin. Robitussin.
Talaga?
Pagtatawanan ka. Putik. Dito pa naman, kailangan syllable, babasahin mo dito. Ay, Diyos ka. Struggle is real.
Di ba yung pronunciation nun?
Withdrawal. Tingnan mo uling ko yung sinasabi niya. Withdrawal. Tsaka maganda rin talaga yung pinapakinggan mo yung puti talaga.
And let's talk about the nursing responsibilities, side effects, and patient education pieces that you want to provide to the patient who is taking these type of medications. And to help us remember all those important concepts, we're going to remember the word benzo. So B is for Beer's List. What is this? Well, this is a list that the American Geriatric Society created of drugs that older adults shouldn't really be taking because it can cause harmful side effects to them. And benzodiazepines is on that list. And whenever an older adult is taking
Benzodiazepine? Yung estudyante ko, benzodiazepine. Oh. Nasa benzodiazepine, pagdataw.
Kaya di ba nakaka-addict yan?
Oo. Ito yung parang downer.
A benzo, it increases the risk majorly of toxicity, dependence on the drug, abuse of the drug, and injuries such as falls. So as a nurse, if you do have an older patient that is taking one of these medications, you want to keep this in the back of your mind. You want to educate the patient or the patient, maybe they have a caregiver about this. And watch out for injuries, especially getting up, moving. They need to call for assistance because they can fall and really hurt themselves. And if you would like to see all the medications that is actually on this Beers list, I have posted a link in the YouTube description and you can access that list so it can help you in practice as well. Then we have E for alcohol, opioids, and CNS depressants, other CNS depressants that should be avoided while taking a benzo. So you definitely want to educate the patient if they are going to be taking a benzo that these other substances do not mix with benzos because they actually increase the risk of overdose and death. And the FDA has actually issued a black box warning on benzos and has educated and told people do not take this drug with these other substances because that can happen. And then we have N for not recommended for long-term use. Benzos are really best for short-term use because whenever they're used long-term, there's an increased risk of the patient becoming dependent on them, abusing them, and having withdrawal signs and symptoms. So if they are taking these long-term, they just can't quit turkey and stop them abruptly. They have to be tapered off them over a Next is Z's for sleepy, hypnotic, sedative effect. So when a patient takes a benzo, that is what it's going to do. It's going to calm them, make them drowsy.
Wala kasi pumapansin sa
You want to
kanila.
educate the patient whenever they do plan on taking a benzodiazepine that they want to avoid any activities that require focus or coordination because they can really injure themselves or someone around them. And the last part of our mnemonic is O, overdose reversal with flumazenil. So flumazenil is the antidote for benzos. And this drug should be used with caution whenever reversing toxicity with benzo. So typically it's used whenever, it's going to benefit the patient a lot more than the risks that are involved. So as a nurse, you want to be familiar with the signs of toxicity of a benzo. So we know that older adults who are taking benzos are definitely at risk for toxicity. And patients who are dependent on the drug because abuse may occur. So whenever that happens, a patient who does become dependent on a benzo, in order for them to get the same effects, those calming, tranquil effects from the drug, they have to keep taking more. They have to have higher dosages. So that can lead to a possible overdose or toxicity. And to help you remember those signs of toxicity, you can remember the word abused. So A stands for altered mental status. So the patient may appear very drowsy or even in a coma. They can also be agitated or extremely confused. Then B is for bradycardia, so slow heart rate. U is for unable to walk or coordinate movements that can have ataxia. S is for speech garbled or slurred. It'll be really hard to understand them when they speak. E is for experience hallucinations or memory loss. And then D is for decreased respirations. Okay, now let's test your knowledge over the material I just covered by taking this quiz question. So this question says, benzodiazepines amplify the effect of what neurotransmitter? Our options are A, serotonin, B, gamma-aminobutyric acid, C, acetylcholine, D, norepinephrine. And the answer is B, because remember, benzodiazepines amplify that neurotransmitter GABA, because what it's going to do after all this binding occurs, it's going to hyperpolarize, and we're going to get a decrease in firing potential, which hence is going to cause some calming, tranquilizing effects to the patient. So that wraps up this review over benzodiazepines. And if you would like more free quiz questions or more reviews over PhRME, you can access the link in the YouTube description. And thank you so much for watching. Hey everyone, it's Sarah, registered nurse, RN.com, and in this video, I'm going to be going over Alzheimer's disease. And as always, whenever you get done watching this YouTube video, you can access the free quiz that will test you on this content. So let's get started. Alzheimer's disease is a chronic brain disease that is a type of dementia. And it's actually the most common form of dementia. And the reason it occurs is because neurons, which are...
May access pa ba tayo sa ano? May access pa ba tayo sa co-working? Ano sa yun? Yung co-working space. Ano yun?
Meron pa tayo pass, pero hindi ko sure pwede pa.
Ilang pass na meron tayo? Tatlo? Tatakbong araw tayo dun eh.
Pero hindi ko alam kung pwede pa. Sobrang tagal na kasi.
5 years na ata eh. No?
Hindi, 3.
3. Try kayo natin. Punta tayo next Friday. Ngayong Friday na
Pero
dapat.
ako.
After mo ng work.
Kaya natin.
Ayaw mo gano'n sa library.
Ha? Yun nga yun. Doon kasi may... Ha?
Hindi siya library.
Pero hindi siya library, pero parang siya... Co-working space. Yung ganun.
Actually, maghanap nga tayo ng library. Tingin ko doon ako nakakaano.
Pwede tayo doon. Doon tayo sa may ano? Doon tayo sa may... Sa may Jumeirah.
May library daw.
Oo. Diba?
Tingnan natin.
specialized nerve cells in your brain, which help you do almost everything that you do on a daily
Kapag
basis.
sa bahay, borlog lang. O sa dorm, natulog ko lang yun.
Ang dami mo kasing pwedeng gawin eh. Mag-ano ka, tatayo ka, ganito.
Kain ka.
Mag-stretch ka, tapos higa. Wala na. Bagsak na.
Pag nakikita mo kasi iba nag-aaral eh.
Oo, mape-pressure ka eh.
Oo.
From form new memories, learn new things, solve problems, make judgment calls, even with your language, being able to understand language that's spoken to being able to actually speak it. They lose the ability to communicate with one another, and then eventually they die. So why does this happen? Well, it actually happens over a period of time. And the reason it does is because of a couple things that I really want you to remember, because it's going to be the foundation for understanding the pathophysiology of Alzheimer's. Well, we have the development of plaques, specifically beta amyloid plaques. And these plaques like to form outside of the neuron. And when they do that, they're going to really impede communication between neuron to neuron and other structures. Then we have the development of neurofibrillary tangles. And these tangles like to form within the neuron itself. So over time, this is going to happen. And then whenever you have a patient who's in the late stage of Alzheimer's disease, the most severe stage, what can result is that this brain tissue can shrink and we have brain atrophy. So over time, as this happens, the result is you're going to see a progressive loss, meaning it's going to get worse over time, where they're going to start to lose their memory. They're going to start having learning problems. They won't be able to problem solve, have judgment calls, communicate with you. They'll have behavior changes. They can have severe depression, mood swings, and then eventually towards the middle stage to the severe stage, they're going to lose the ability to have self-care. So they're going to be totally dependent on a caregiver. Now let's look at some interesting facts about Alzheimer's disease. So according to the CDC, they say that this is the 5th leading cause of death among adults ages 65 or older. Also, in 2021, it was estimated that 6.2 million Americans lived with Alzheimer's disease. Now, this is actually expected to increase. By 2060, they say that 14 million people could be living with this disease. So as you can see, this is a huge deal. And as healthcare providers, we really have to be familiar with this disease. Now, women are more likely than men to develop Alzheimer's disease. And the reason for this, they say, is because women tend to live longer than men. And Hispanics and African Americans tend to have a higher risk for developing this disease. Now, in regards to signs and symptoms, most patients don't start showing signs and symptoms until they're over the age of 60. However, in some patients, this is not the case. They may start showing signs and symptoms a lot earlier. Now, risk factors for Alzheimer's disease include having a family history, so they have a genetic link, or they're older, so their age, their gender, they're female, or they smoke, they're diabetic, or have heart disease. Now, there's various stages of Alzheimer's disease. You can start out just having mild cognitive impairment, go all the way to the severe late stage. And it's really dependent on the patient how fast they're going to go through each stage. And I'm going to be going over the stages a little bit later in the lecture. And the exact cause of Alzheimer's disease is not fully understood. They know that there's plaques and tangles, but there's still a lot that we need to learn about this disease. And there's currently no cure, but there are medications available to help decrease symptoms. When we talk about the pathophysiology of this disease, we first have to go back and look at the neuron. So you have billions of neurons in your brain, and these neurons help you function. And they're very busy all the time. They're constantly communicating with each other, sending electrical signals, and releasing neurotransmitters to help communicate their messages. So let's look at this healthy neuron here, look at its parts and how a message is sent throughout a neuron. So protruding off of the neuron is a very important structure called the dendrite. Now dendrites, they remind me of tree branches that are just hanging out, waiting for something to land on it. And in this case, with the dendrite here, it's waiting for an electrical signal to come to it. So the dendrites receive electrical signals from, let's say, other neurons, and they take that electrical signal and take it to the cell body of the neuron. The cell body has a nucleus, and it's going to process that message that it just received. So here you can see a neuron sending the message to the dendrite. So here we have the axon with the axon terminals, and then a synapse, which releases a neurotransmitter. So the neurotransmitter is what really communicates that message that needs to be sent to this other neuron. And there's different types of neurotransmitters in your body. So these little chemical messengers can send exciting messages, or they can send inhibitory messages. Some neurotransmitters actually have the properties of being able to do both. So two neurotransmitters I want you to remember are called acetylcholine and glutamate. Because whenever I go over the medications used to treat Alzheimer's disease, it will make sense how these medications affect these two neurotransmitters. So we have the message sent up through our dendrite. It's hit our cell body. Now it needs to go down through the axon. The axon carries that message away from the cell body. Then it goes, hits the axon terminals. You have the synapse, you have neurotransmitters released. Now, this can send a signal. These neurons can send signals to other neurons. They can send them to muscles. They can send them to glands. It's whatever they're targeting with their little neurotransmitter message. So, in order for all this to work beautifully, you have to have healthy neurons that are free from any weird debris inside of them or any debris outside that could be impeding this communication. So our body knows this, and it has these cool cells that hang out around the neuron to help protect the cell's integrity. One type of cell I want you to be familiar with is called a microglia. Microglia like to hang out around the neuron, and they have many functions, but one main function they have is that they go around surveilling the neuron's environment, and if they see any dangerous debris or chemicals or anything like that, they go and they eat it. So to remove it. So they play a role in inflammation. Now, in patients who have Alzheimer's disease, unfortunately, their neurons aren't healthy like this. They instead have problems where they're not being able to communicate with each other. So they lose the ability to thrive and live, and instead they die. So why does this happen? Well, it's due to the formation of beta amyloid plaques and neurofibrillary tangles. So first, let's take a look at these plaques. These plaques are found outside of the neuron, and they congregate together, and the reason we call them beta amyloid plaques is because they're made up of beta amyloid. And they really impede communication among the neurons. They set off inflammation with these microglia cells, which makes it worse for the neuron, and then the neuron can eventually die. Now, what happens in Alzheimer's disease is it tends to start in the inside central, and over the years it will spread out where it will hit the cerebral cortex. So how in the world do these plaques get here? Well, to help us understand that, let's take a look at the cell membrane in the nerve cell. So crossing this cell membrane is a protein called amyloid precursor protein. And as this protein crosses over, enzymes from outside the cell membrane and inside the cell membrane cause this protein to break down into small pieces of peptides. Now, normally these peptides that have broken off from this amyloid precursor protein will be metabolized and removed from outside the neuron. But in Alzheimer's disease, the enzyme that is helping the beta amyloid peptide to break off isn't working right. So large strands are left over, which are not metabolized right, and they are beta amyloid peptides. So these beta amyloid peptides start to congregate together in between these neurons and create plaques over time. Then there's the development of neurofibrillary tangles. And these tangles like to hang out on the inside of the neuron, whereas the plaques were on the outside. So these tangles are also made up of a special type of protein called tau. Now, tau is really important for helping provide structure to the microtubules. So let's take a look at the microtubules. So here's an example of a microtubule. At the top, we have a healthy neuron. Its microtubule has a nice shape, it's intact. But the one on the bottom, this is a diseased neuron due to Alzheimer's disease. And the microtubule is not intact, it's like falling apart. So the microtubules play a vital role in delivering nutrients throughout that neuron and help giving it shape. However, in Alzheimer's disease, these tau proteins, they quit working and they change this microtubule. So this causes this microtubule to fall apart, and when this falls apart, guess what's going to happen? It's going to affect how nutrients is being delivered throughout that neuron, and that's going to cause the neuron to get sick and become unhealthy. And then because of this, these tau proteins, they are no longer providing structure to this microtubule, so they're just hanging out and they start to clump together. And this is what forms these tangles. And these tangles will affect how the neuron works on the inside and will eventually die. So as I pointed out before, when these neurons start dying, this is really going to affect brain tissue, and this is going to cause the brain tissue to shrink and atrophy. So now let's review the parts of the brain, because it's going to make a whole lot more sense whenever you're seeing these certain signs and symptoms presenting in a patient with Alzheimer's disease, if you know what areas of the brain are affected and what they normally should be doing. So your brain can be divided into certain sections based on its function. Now, in Alzheimer's disease, brain changes start occurring way before the patient actually starts having signs and symptoms. And it tends to start in this middle part of the brain. One structure that's affected early on is called the hippocampus. And your hippocampus is responsible for you learning new things and your memory. So forming new memories and your spatial memory, like navigating around or finding objects that you place somewhere. Also affected is the interhinal area, and this is responsible for you understanding time, again, memory, a sense of direction, and the amygdala. And this is responsible for your emotional memory, so how you respond to the environment. So as you can see, we have memory here in this part of the brain. So that is why in those early parts of Alzheimer's, you start to see memory changes in the patient. They start out subtly, and then they gradually, progressively get worse, where the patient will no longer have any memory at all. Now, as the disease progresses and more plaques and tangles form within neurons of the brain, it's going to spread and it's going to affect a huge chunk of the brain known as the cerebral cortex. And the cerebral cortex is that outside layer that surrounds the cerebrum. So it can be divided into different lobes based on their functions. So you have the parietal lobe, you have the frontal lobe, the temporal lobe, and the occipital lobe. And each lobe has its own little thing it does. For instance, the frontal lobe is responsible for thinking, speaking, memory, and movement. The parietal lobe is responsible for language and touch. Occipital lobe is vision and color perception. And the temporal lobe is responsible for hearing, learning, and feelings. So as you see with the function of each of these lobes, as Alzheimer's progresses and affects these lobes, the patient's going to have signs and symptoms that correlate with the function of each lobe. For instance, the frontal lobe, if it's being really affected, the patient's going to have problems thinking, speaking, with memory and movement. Or the parietal, they're going to have issues with language. So in terms of signs and symptoms, let's look at some important terms that you want to remember for exams and in practice that are used to describe some signs and symptoms that may be displayed in a patient with Alzheimer's disease. So Alzheimer's disease starts with A. Unfortunately, all these terms start with A, and they end in IA. So the first one is apraxia. Apraxia is where the patient can't perform certain motor movements. So let's say they need to brush their teeth. Well, they just don't possess the ability to perform those motor skills needed to pick up that toothbrush, put the toothpaste on the toothbrush, rinse it under water, and then brush their teeth. They can't do that. They need help. Next, we have aphasia. Aphasia is where they can't understand speech or create it. So you may be talking to them, giving them some instructions or something, or telling them about something, but they just don't understand those words. So sometimes it's helpful to have a card that is showing on an image of what you need them to do. That sometimes can help with communication. And how I remember the meaning of this word is, remember a phrase, like with speech you utter a phrase or someone says a phrase, and that helps me remember aphasia because you have, it sort of looks like phrase in there. Then we have agnosia. Agnosia is where the patient can't recognize objects, people, or interpret their senses. And there's different types of agnosia. So with this, some patients may not recognize a spoon that you're giving them. They don't really know what it's for. Or people they've normally seen. Or
Bruce Willis? Dementia sa kanya.
Primary progressive aphasia.
Pero may dementia siya.
May dementia na siya.
Yung aphasia, yun yung part lang ng ano.
Just sa mga symptoms.
Symptoms.
senses. For instance, they have the sensation they need to use the bathroom, like urinate, but they don't really know what to do with it, so they're incontinent. Or you give them some food to eat, and they don't recognize what it is that they're eating. Their senses are affected. And how I remember this is look at recognize. You have the GN, and we have agnosia. So GN, you're not being able to recognize. Then we have amnesia, and this is memory loss. They cannot recall memories. Maybe they don't know who they are, what their birthday is, their address, etc. And then lastly, we have anomia. And anomia is where they can't recall the names of objects. So let's say you have an apple in front of them. They've seen it before, but they don't know what it is. They can't pull from their brain file, oh, this is an apple. They can't connect that. And how I remember this is you have name, N-A-M, and then nom. It's sort of similar to that. Now let's look at the stages of Alzheimer's disease, because this is going to help us see those other signs and symptoms that present in each.
Ito yung sa movie na ano, parang pangalan yung love story ng matanda. Hindi. The Notebook.
Pero yung alam mo yung pelikula ni Adam Sandler tsaka ni...
Drew Barrymore?
Totoo ba yan?
Ha?
Yung short-term memory.
Stage. First, we have preclinical Alzheimer's disease, and this is where changes are occurring in the brain, but no symptoms are noted, and this can happen over years. Next is mild cognitive impairment, and this is where the patient starts to have memory changes that are subtle, but it doesn't affect their activities. They may start forgetting recent commitments, new people they've met, or conversations they've had recently, and they start to get confused on places and time. And they may report, something just doesn't feel right in my brain. It's like I can't think clearly. And this stage can last for several years. Next is mild Alzheimer's disease, and this is early stage Alzheimer's. This is typically when patients are diagnosed with Alzheimer's disease. They're going to start having mild forgetfulness that is noticed by the patient, family members, and friends. And it's beginning to affect some parts of their functioning. They're going to have short-term memory problems, like they're going to frequently lose objects, can't remember new material they've just learned, maybe start having trouble at their jobs, learning new things. They'll start repeating themselves and asking the same questions over and over. Language problems can start, like they're trying to talk to you, but they forget a word. And they may start having mental instability, which is going to be recognized by family members, like depression, confusion, having sleep problems, things that just isn't normal for the patient. Now, the thing with this stage is that they can still function and be independent. What's going on with them in their brain isn't affecting their ability to live out life. But during this time, if the patient's diagnosed, knows they have Alzheimer's, this is when the nurse wants to go over with the patient about the progression of the disease and tell the patient it's time to start planning for the future and incorporating family members as they want to, like discussing end-of-life care, estate planning, and so forth. And this stage lasts a couple of years. Next is moderate Alzheimer's disease, the middle stage. Now, this is when things start to change. Confusion now sets in that affects the patient's ability to function, and they're going to need help. Safety is a main issue with this patient, along with helping them with their self-care and medical needs. So their judgment is going to start to become lapsed. They are going to have major safety issues, getting lost, doing a thing called wandering, which I'm going to go over in the nursing interventions. They will forget how to cook or use objects with hygiene. They need help with the bathroom, how to dress, especially depending on the weather. They may not pick the right outfit. Confusing family members, having sleep problems, major mental instability, where they have episodes of anger and anxiety, and hallucinations. So during this stage, the patient is active. They can get up and move around, but they don't have the cognitive ability to make sure that they're doing the appropriate things without getting hurt. Also, caregivers may start recognizing a phenomenon called sundowner syndrome. And as a nurse, I have seen this. This is absolutely real. And as the day draws closer to evening, the patient will start to get confused. They may become more agitated. They'll start hallucinating and just get really restless. So this stage for the caregiver is a very intense time because the patient must be monitored at all times and requires a lot of supervision and care. And this stage of Alzheimer's is actually the longest stage of all. Then lastly, we have the severe Alzheimer's disease stage called late stage. And this is where symptoms are very severe. A lot of times they're no longer able to participate in life, like have language communication will be very minimal with limited motor activities. They're going to spend much of their time in bed, sitting, staring. They can start to have problems with swallowing, eating, and they're going to need constant care during this time. Now, because they start having issues with swallowing, like called dysphagia, they are at huge risk for lung infections like pneumonia. A lot of times patients develop this. So the patient needs to be evaluated by a speech-language pathologist to see if they may need a feeding tube, or their liquids need to be thickened, or their food consistency should be altered to help protect those lungs. Now, interacting with the patient during this stage is just as important as interacting with them before they progress to this stage. But communication does change a little bit because, like I said, they're going to have minimal communication skills. So using nonverbal communication, like facial expression, body gestures is good. Using touch as needed, and just providing a calming, relaxing environment for the patient during the day, like with music, promotes good quality care. Now let's talk about testing for Alzheimer's disease. So with this disease, brain changes are occurring in the brain before signs and symptoms even start manifesting themselves. So early detection is key for patients so they can prepare and potentially get on any medications that can help manage symptoms. Because remember, there's no cure at this time for Alzheimer's. So with Alzheimer's, you have to rule out any other condition that could be causing this cognitive problem in this patient. For instance, brain tumors could do this, stroke, brain injury, and so forth. So a series of tests have to be performed because there's really no one conclusive or even two tests that say, hey, this person has Alzheimer's disease. We have to look at a whole variety of tests to determine that. So first, one thing that can be done is very easy, not invasive at all, is called a cognitive assessment. And this is where the patient is asked questions to test their memory, judgment, and thinking. Also, mental evaluation can be done along with diagnostic imaging. For instance, they can do an MRI or a CT scan, look at the brain, make sure there's no tumors or a stroke has occurred. And they can order an amyloid PET scan. This scan can look for those beta amyloid plaques in the brain. Also, biomarkers can be identified in the body. So one way we can do that is to do a spinal tap. So they'll go in, they will remove cerebral spinal fluid, CSF, from the patient and test it for those proteins that we just went over in the patho, see if those are present. And recently, the NIH just reported in February of 2022 that there's a new blood test available that can test for those beta amyloid proteins. So that's really exciting. In addition, genetic testing can be used, but this is really more for research. So it can test for apolipoprotein E and see what their ApoE status is. And the thing with this is that just if a patient gets a positive result doesn't necessarily mean they're going to go on to develop Alzheimer's. Now let's look at the nurse's role with Alzheimer's disease. So as a nurse, you're going to be playing a role throughout all the stages of Alzheimer's, from helping a patient identify potential signs and symptoms of Alzheimer's, to medication, to how the disease progresses, educating the patient and the caregiver, and identifying and helping the caregiver determine when they need times for breaks, what resources they have available for them, like respite care. So all stages are important, but the most trying stages of Alzheimer's disease is that middle stage to that late stage. The middle stage, the patient is active, but they have impaired judgment and memory, and they require immense supervision to protect their safety and help them with their self-care. And then the late stage, they need total care. So to help us remember our role as a nurse, because the middle stage is so involved, we're going to remember the 7 M's. First is memory. As we've discussed throughout everything, the patient, when their first signs and symptoms, is going to be memory, and it's going to progress as it gets worse because the big memory areas of the brain are being affected, especially early on. So as your role, what you're going to be doing is you're going to be reorienting the patient often. You're going to be reminding them how to do certain things, or people that they have forgot. That what comes in handy with that is using imagery, little picture cards to help identify rooms, identify objects throughout the house, or even identify people. And you want to keep patient during this time. The patient may be repeating themselves a lot, asking the same questions over and over, so you have to be patient. Keep things simple. They love to do tasks, and keeping them busy is a great way for them to use those muscles and to use their mind and just to stay focused as much as they can. So when you give them a task, give them something that's simple. Do it in one step instead of several steps. And whenever they do forget, do not scold them or belittle them. This could cause agitation and cause them to have an emotional outburst and become really upset. Next is movement. A patient who has Alzheimer's disease, it's very important that we help them stay as independent as much as their disease allows, because we want them to maintain their motor functions and their upper body strength and lower body strength. So we want to make sure that they're following routines. As they start getting into those advanced stages, we are going to have to guide them in doing their morning care, their breakfast, toileting, activities throughout the day, have periods of exercise, but also have periods of rest. And exercise is very important for them. Getting outside, getting with that sunlight, making sure they have exposure to that, because that has shown to decrease sundowners a little bit. And then it helps burn off that energy, which can decrease them wanting to wander about and become restless. And it's important that they play fun, easy games that can help with their memory, like, for instance, jigsaw puzzles or playing cards, anything that's simple for them to do. Then we have mental health. So patients with Alzheimer's disease can have frequent mood swings. One day they may be happy.
Oopsie.
Next, we got some drag and drop items coming up. So for drag and drop clothes items, you're gonna need to select a response and drag it to the right target. But hey, There might be more than one right answer here. So if you choose the wrong one, don't worry, because you can simply drag it back to the list or even ditch it altogether. Then we've got drag and drop rationale items. It's a simple sentence with one or two cause and effects, and you gotta pick the right choice.
Hey, Alpha Nurses, I'm Sandra from AlphaNurseGuide.com. NCLEX Review 1, 200 NCLEX practice questions. You can get my study guides and Etsy. You can follow me on Facebook, Instagram, and TikTok for more content. All links are in the description. Without the way, let's get started.
The nurse is collecting data from a client who has been diagnosed with placenta previa. Which findings should the nurse expect to note? Select all that apply. A. Uterine rigidity. B. Uterine tenderness. C. Severe abdominal pain. D. Bright red vaginal bleeding. E. Soft, relaxed, and non-tender uterus. The correct answers are D. Bright red vaginal bleeding, and E. Soft, relaxed, and non-tender uterus. Rationale: painless bright red vaginal. Bleeding during the second or third trimester of pregnancy is a sign of placenta previa. The client will have a soft and relaxed non-tender uterus. In clients with abruptio placentae, severe abdominal pain is present. Uterine tenderness accompanies placental abruption. Additionally, with abruptio placentae, the abdomen will feel hard and board-like on palpation as the blood penetrates the myometrium and causes uterine irritability. The community health nurse has completed a teaching session about anthrax with members of the community. The nurse reinforcing the teaching to those attending that anthrax can be transmitted via which routes? Select all that apply. A. Skin. B. Kissing. C. Inhalation. D. Gastrointestinal. E. Direct contact with an infected individual. The correct answers are A. Skin, C. Inhalation, and D. Gastrointestinal. Rationale: anthrax is caused by Bacillus anthracis, and it can be contracted through the digestive system, abrasions in the skin, or inhalation. It cannot be spread from person to person. The nurse is assisting with planning care for a client with an internal radiation implant, which should be included in the plan of care. Select all that apply. A. Wearing gloves when emptying the client's bedpan. B. Keeping all linens in the room until the implant is removed. C. Wearing a film badge when in the client's room. D. Wearing a lead apron when providing direct care to the client. E. Placing the client